All right, let's jump right in. Today, we're cracking a case that can pop up out of nowhere and be incredibly serious. Acute kidney injury, or AKI. We're going to approach this just like a clinical investigation, working through the evidence step by step to figure out how to spot it and manage it. Let's get started.
So here's how we're going to break this down. Think of it like a detective story. We'll open the case to get the basics. Then, like any good investigator, we'll gather clues and analyze the evidence. After that, we'll pinpoint our main suspects, drop an action plan, and finally close the case by looking at what happens next.
Okay, so first up in our investigation, what are we actually talking about when we say acute kidney injury? Let's make sure we've got the fundamentals down before we start digging any deeper.
So at its most basic level, AKI is a really sudden, really rapid drop in how well the kidneys are working. I mean, they just kind of stop filtering waste effectively. So you get this buildup of stuff like blood urea nitrogen, BUN, and creatinine. And this is super important. It's not just about waste. The body's whole system for managing fluids, electrolytes, and even its pH balance gets thrown completely out of whack. It's a full-blown systemic crisis, not just a kidney problem.
And this right here is why we're treating this like an urgent investigation. With AKI, you're literally racing against the clock. If we can find a cause that's reversible and find it fast, we can turn things around. It can honestly be the difference between a full recovery and a really bad outcome. So having a solid game plan is everything.
All right, we know what we're looking for. So now our investigation starts at the most important place, with the patient. It's time to start gathering some clues.
You know, every good investigation really boils down to asking the right questions. And before we even think about labs or imaging, the patient's own story can give us our biggest leads. We just have to know what to ask.
And each one of these questions is like a breadcrumb trail. You ask about fever and a rash? Maybe we're looking at something autoimmune. They're having trouble peeing? Okay, that screams blockage. And you've got to ask about recent meds. Things like NSAIDs or ACE inhibitors are classic culprits. Or maybe they just had a CT scan with IV contrast. That's often the smoking gun right there. Every single answer helps us narrow down our list of suspects.
Okay, so after we've listened, we look. Is the patient running dry, or are they overloaded with fluid? This is a huge fork in the road for our investigation. If you see signs of dehydration, what we call hypovolemia, that tells you the kidneys might just be starved of blood. But if you see signs of fluid overload, hypervolemia, that points more towards the kidneys themselves failing to do their job. Getting this one assessment right can steer our entire investigation. Okay, we've got our initial clues from the patient. Now it's time to head to the lab. This is kind of like the forensics part of our case, where we dig into the hard data to get definitive proof of what's going on.
And believe it or not, in the world of AKI, you get the most bang for your buck from a simple urinalysis. Seriously. It's like getting a direct dispatch from the scene of the crime. That one little sample is a window right into what the kidney is doing or not doing.
And just look at what we can find in there. If the sediment is clean, it's a pretty good sign the problem is happening before the kidneys even get the blood. That's what we call pre-renal. But if you see these things called muddy brown granular casts, boom, that's the classic textbook sign of acute tubular necrosis, or ATN. That means the kidney's own machinery is damaged. Finding one of these specific clues is huge. It can basically solve this part of the mystery for us.
And it's not just what we can see, it's the chemistry too. Think about it. If the problem is before the kidney, a healthy kidney is going to panic and try to hold on to every last drop of sodium and water it can. So the sodium in the urine will be super low. But in ATN, the kidney is broken. It can't reabsorb sodium, so it just spills right out into the urine. It's just another brilliant piece of evidence that helps us tell the two apart.
Okay, we've talked to the patient, we've done the exam, we've analyzed the lab evidence. Now we can take all that info and really narrow our focus down to one of three main suspects.
So after all that detective work, it all comes down to this one question. Where is the problem actually coming from? Is it before the kidney, inside the kidney, or after the kidney? Answering this is how we crack the case.
And here they are, our three categories. The plumbing analogy is perfect here. A pre-renal problem is like a kink in the hose before the filter, so not enough water gets through. An intrarenal problem means the filter itself is busted. And a post-renal problem? That's a clog in the pipe after the filter, causing everything to back up.
Pre-renal causes are, by far, the most common culprits we see. This is all about not getting enough blood flow, or perfusion, to the kidneys.
It could be from straightforward volume loss, like from a hemorrhage or bad diarrhea, or it can be from bigger issues like heart failure or sepsis, where the body's whole circulatory system is struggling, even if there's technically enough fluid on board.
Next up, we have our intrarenal causes. This is where the kidney tissue itself gets damaged. And the number one suspect here is usually acute tubular necrosis, ATN. This can happen from that low blood flow we talked about going on for too long, or from direct poisons, nephrotoxins. We're talking about things like IV contrast dye for scans, certain antibiotics, even stuff released from a major muscle injury can do it.
Okay, we've got our prime suspect, so the investigation now pivots from what's wrong to what do we do about it. Based on everything we found, what's our action plan?
And the action plan is a really clear two-step approach. Step 1, stabilize the patient, period. That means you handle any immediate life threats, like crazy high potassium or acid-based problems. Then, step 2 is to go after the root cause we just worked so hard to find. If it's pre-renal from dehydration, you give fluids. Post-renal from a blockage, you relieve the obstruction, maybe with a catheter. Intrarenal from a drug, you stop the drug. The treatment flows right from the diagnosis.
But sometimes, our best efforts aren't enough, and we have to call in the heavy artillery, dialysis. And these are the non-negotiable, absolute reasons to do it. We're talking life-threatening situations. Potassium so high it could stop the heart. So much fluid overload the patient can't breathe. Or when the buildup of toxins, uremia, starts affecting the brain. In those moments, dialysis isn't just a treatment, it's a lifesaver.
All right, we've got our action plan in motion. So to wrap up our case, let's look at the possible outcomes. What are the dangers along the way, and what's the long-term outlook for someone who's been through this?
And let me tell you, the stakes are incredibly high. For patients who aren't in the ICU, the mortality rate is already pretty sobering. But look what happens when a patient is sick enough to be in the ICU. That rate can skyrocket, sometimes as high as 80%. This is why every single step of this investigation, from spotting it early to acting fast, is so unbelievably critical.
But here's the really hopeful and honestly the most important takeaway from this whole thing. For the patients who survive that initial acute illness, the chance of their kidneys recovering is actually pretty good. This isn't always a life sentence of kidney failure, and it just hammers home our central point. A fast, accurate investigation to find and reverse the cause makes all the difference in the world. And that really brings our case to a close. We've walked through how to react once AKI is already on the scene, but it leaves us with a really important question for the future. How do we get ahead of this? Given that it often starts so silently, how can we do a better job of predicting and maybe even preventing the very first signs of trouble in our most high-risk patients? That's the next big challenge for all of us. Thanks for joining me on this one.